Ladies and gentlemen, thank you for joining Lake Superior QIN Hospital Outpatient Department's Ambulatory Surgery Center's Open Forum for QI. Let's talk. Donna Madras. Donna, you may now begin.
Thank you. Good afternoon, and thank you all for joining us for the Hospital Outpatient Department Ambulatory Surgery Center Open Forum for Quality Improvement. Let's talk colonoscopy and OAS CAHPS measures. Today, we hope you came prepared to discuss and share some barriers and lessons learned in the hospital outpatient departments and ambulatory surgery centers regarding both the colonoscopy measures and the OAS CAHPS measures. We know that these measures are the same for both type settings, and so that's why we decided to bring you together today. My name is Donna Madras again, and I am a Senior Clinical Quality Consultant with MPRO. I represent Michigan in the Lake Superior Quality Innovation Network. With me today is Sarah Brinkman, the Program Manager from Stratus Health, representing Minnesota, and Ross Gatsky, Project Specialist on Value-Based Purchasing from Medistar, representing Wisconsin. And so they will help me in supporting the chat function and keeping the discussion going today. I prepared the slide presentation. It's really intended just to facilitate discussion for each of the measures. And we ask that you feel free to ask questions and share what your barriers are or were and what lessons you've learned, and share any success and best practices at any time using the chat function or during our discussion. I would like to mention that Lake Superior Quality Innovation Network is contracted with the Centers for Medicare and Medicaid Services to assist you with the OQR, Hospital Outpatient Quality Reporting Program, and Ambulatory Surgery Center Quality Program measure performance improvement. We realize that the performance for both the outpatient and ambulatory surgery centers' clinical measures have mostly topped out over time, and there's little room for improvement, which is why we decided to hold this open forum. We want you to be able to have the opportunity to discuss, share, and learn from each other about your different experiences, as some of them may help the other settings of care. We also would like to add that this is an open forum, and it is really intended to benefit you. And so we really hope that what you put into it today is what you will get out of it. So we encourage discussion from all participants. And knowing that it is painful sometimes to get the conversation started, we hope you all feel comfortable enough to share either by speaking or using the chat forum. So let's get this party started. And one. Okay. So our objectives for today are simple. We basically want to facilitate discussion and have you share your tips for collecting and submitting data for these measures, and share your lessons learned, as I mentioned. And we also want to make sure that, the data that you submit is complete and correct to make it meaningful, because only then can we begin to implement performance improvement. So we do want to hear how you are implementing the new OAS CAHPS, or the new OAS CAHPS measures, and how you are preparing to collect and submit that data. The OP29 or ASC9 measure. That is the appropriate follow-up interval for normal colonoscopy in average risk patients. Now, I have taken the actual description straight from the specifications manual. It's a percentage of patients aged 50 to 75 that received a screening colonoscopy without biopsy or polypectomy, who've had a recommended follow-up interval of at least 10 years for a repeat colonoscopy documented in their colonoscopy report. These two measures, OQR and for the ASC, are web-based measures. So you will have to, and you've been doing this, but you would have to enter this numerator and denominator into a web-based tool on the QualityNet site. And the tool requires the numerator as all colonoscopies with documented follow-up for a repeat scope in 10 years. And then your denominator, your denominator is all patients aged 50 to 75 who are receiving screening colonoscopy, biopsy, or polypectomy. There are exclusions to the measure with documentation of medical reasons for not recommending a 10-year follow-up scope. And the medical reasons included the high-risk patients, such as diverticulitis, or if there's family history or inadequate prep. And the medical reasons are recommended shorter follow-up intervals at the discretion of the physician, and those are not included in your denominator. So now if we move to OSC 30 and OP30 and ASC 10 got the colonoscopy interval for patients with a history of adenomatous polyp avoidance of inappropriate use measure. I'm going to have discussion following both of these once we go through them because they were both implemented in 2014 and they really probably have the same caveats for collecting the data, so I figured we would just group those together. So this one, the description again from the spec manual, is the percentage of patients 18 and older having surveillance colonoscopy with a history of a prior polyp in previous colonoscopy who have had a follow-up interval of 3 years or more since their last scope. Again, this is a web-based measure with a numerator of patients with an interval of 3 or more years since their last scope, and denominator is for all patients 18 and older receiving a surveillance scope with a history of a prior colonic polyp in previous colonoscopy findings. As with the other measures, there are exclusions. There may be documented medical reason for an interval of less than 3 years, such as patients with a higher risk of colon or with an inadequate prep. There's a documentation of system reasons as clearly documented in the medical record for an interval of less than 3 years since the last colonoscopy. So this brings us to the first discussion and sharing point. So we just wanted to really see since you've been collecting this since 2014, you've had time to work out some bugs. And have you had any issues or have you submitted several Q&As? Have you gotten responses that were helpful? Do you have any lessons learned that you'd like to share? I don't know if the two different settings of care may have ideas or best practices that they've shared with each other that would be great at this time. If Adanya, if you would like to open the line for any discussions or questions at this time.
Absolutely. Ladies and gentlemen, if you would like to ask a question and or if you have a discussion, please press the number 1 key. Again, ladies and gentlemen, if you would like to ask a question and or have a discussion that you would like to talk about, please press the number 1 key. Currently, there's no one in queue at the moment.
Anything in chat?
There isn't at this time.
We actually have one from an info guest. You may now begin.
Okay. Thank you.
Sorry, my name is Kristen. Just a question about documenting the prior date of colonoscopy. I think this has probably been asked routinely, but just to clarify one more time as we're collecting our final submission data. So it's appropriate if the last date of colonoscopy is available on record in the EMR anywhere. So say if the patient had their previous colonoscopy at our center.
Yeah, so is that for the OP29
report?
Okay.
Sorry, I think you cut off at one point. You were mentioning if it was in the EHR anywhere, and then you cut out for just a moment. If you want to repeat the question.
Unfortunately, I think they.
Oh, did they drop off?
Yeah, I think they did. Maybe they'll come back on shortly. Thanks.
We do have one comment in the chat box, Donna. Michelle Nolander has said that they've had issues with their EHR and documentation systems, but have upgraded to a new system along with using GI Quick.
Okay. Thank you for that.
Michelle, could you indicate in the chat if you are from an ASC or from an outpatient department of a hospital? Please. Michelle is in an outpatient department with a hospital.
Okay, great. Okay. And for the question that came in on the documentation for the dated previous scope, we go right to the specification manual to actually make sure of the source of documentation. And was that if you could put in the chat maybe that was for an outpatient, was it OP29, I believe? So it's outpatient?
Yeah, I believe Donna, this is Rob. I believe that's what she was referring to. Was,
okay.
I think she's referring to they need at least documentation in the EMR of the last colonoscopy.
It doesn't have to be in the report. I don't know that they can pull it from anywhere in the EHR. I would have to go to the spec manual. Okay, so
yes, okay. It needs the latest colonoscopy or the last colonoscopy does need to be documented
in the colonoscopy report.
Correct.
Not from anywhere in the EHR. Okay. Okay.
So, Donna, Kristen Strahe, who I believe posed the question over the phone, has clarified that she is from an ASC.
Okay, great. Okay. Did we answer Kristen's question? I'm sorry. Oh, she was just making a comment about that she's an ASC and they have implemented the GI Works in their EHR to collect that data. Thank you for sharing that. Is there anything else that people found they had a lot of questions on and how they solved the issues?
We have a question from Kate Thornton, who wants to know if documentation within the in an outpatient surgical department.
Okay. Okay, again, I believe we have to get back to you. I believe that has to be from the spec manual. I'm answered from the spec manual. I'm trying to pull that up right now. But I thought that the documentation that I've looked at says that it has to be documented in the colonoscopy report. So I will get back to you on that as I go. I'm in the process of pulling that up now. So bear with me. Is there any other question that I can come back to this one?
Yes, Barb Anderson from an ASC is wondering about colonoscopies that were done outside of the facility that they are unable to get records on. She says we can't take a patient's reported date of colonoscopy and outcome if it's documented in the provider note, ?
Right. Has anybody else run into this, and how have you handled it?
As a reminder, if you would like to speak over the phone, I believe you press the number 1.
Okay, we do have a question from Christine Trey. You may go ahead and begin your question.
Just going to respond to the previous question. So I'm under the understanding if the patient does not recall last date and we're unable to obtain the record, that as long as the physician documents last date of colonoscopy unknown, then I believe it's an excluded case, even with the indication of personal history of polyps by patient recollection.
Okay. And I think there was, do you have that? I think it was in a Q&A also.
Yeah, I believe you're right.
Mm-hmm. So it is excluded then at that point.
Yes, that is correct. I found it in the Q&A. So it says if you are unable to find documentation of the date of the previous colonoscopy, or you are unable to determine the interval since the last colonoscopy, the patient cannot be excluded from the denominator based on a medical or system reason. The patient will be included in the denominator population and not in the numerator population.
Great. Thank you, Ross.
Yeah, so you do, and that obviously remains one of the pretty difficult barriers. Is just that the lack of the information exchange between patients that have been to multiple facilities, especially when in the colonoscopy, over 10 years, there's a chance that patients are going to bounce around different facilities. So that does remain one of the barriers, is getting access to the information that documents their last colonoscopy.
Okay, again, ladies and gentlemen, if you would like to ask a question and or if you have something you need to discuss, please press the number 1 key. Again, ladies and gentlemen, if you would like to ask a question or discussion, please press the number 1 key.
Okay, I think we'll get back to the people that had these questions that we may not have answered fully, like Michelle. And as we go, we will collect these, and if you feel free to put them in chat, and we will get back to you either if you leave your email address in chat, or at the end we have our email address so you can contact us. Again, we're hoping to facilitate discussion between participants on the line, so I appreciate everybody that's chiming in. That's awesome. So we're going to go ahead then and move on to the next measure, which is OP32 or ASC 12, which is the 7-day risk standardized hospital visit after outpatient colonoscopy. The description is that the measure estimates a facility level rate risk of a standardized all-cause unplanned hospital visit within 7 days of an outpatient colonoscopy among Medicare fee-for-service patients age 65 and older. The measure is not a it's not a web-based this time, it's an outcome measure, and it is claims-based. CMS uses Medicare's administrative claims and Medicare enrollment data. So there is no facility abstraction or submission of this data. The numerator is for all-cause unplanned hospital visits within 7 days, and a hospital visit is defined as any ED visit, observation stay, or inpatient admission. And the denominator includes all low-risk colonoscopies in an outpatient setting or age 65 and older. There are exclusions for this measure also. Patients are excluded if they have inflammatory bowel disease, diverticulitis, or if the colonoscopies for patients who lack continuous enrollment in the Medicare Part A or B in 7 days after the procedure, and colonoscopies that are billed on the same day as an ED visit or observation stay. There are risk adjustments for this measure also. One is a 2-level hierarchical logistic regression model to estimate facility level. Other is a risk standardized model with a 15-patient level variable such as age and concomitant upper GI scope, polypectomy during the procedure, as well as 12 comorbidity variables. And the different patient level risk adjustments are for demographic, procedure factors, and comorbidities. Now, this measure was implemented in 2016 for 2018 payment year. So you have received dry runs. There should have been one from 2015 was your initial dry run, and then you also received another report in September of 16, I think December of 16, as well as March of 2017. And they were providing these reports so that you would be able to identify issues with patients coming back and having a hospital visit within 7 days, and whether you were able to attribute it to CAHPS coding issues. And so we just want to talk about that and see if you have been able to use that claims detail report. Have you all had access to it, and you accessed it via your QualityNet secure file transfer, and what you've done with it. So we hope to hear some feedback as to your status with this measure. If you could open the line, Sadania.
Well, certainly, ladies and gentlemen, if you would like to ask a question and or discussion, please press the number 1 key. Again, ladies and gentlemen, if you would like to ask a question and or discussion, please press the number 1 key. There's no questions in queue at the moment.
Sarah, is there anything in chat?
There isn't in regard to this most recent measure that we were speaking of, although someone did share that they received a response from OQR support in the form of an email regarding the previous measures that said a statement patient or documentation in the medical record indicating the last colonoscopy would be sufficient for establishing the interval. So we will work on trying to find a published source of information for that, or seeing if there's another maybe Q&A that addresses that as well. But there haven't been any comments about this most recent measure.
Okay, great. Thank you. Is there anyone that has not seen their report, the claims detail report, or are not working on it, or so nobody's had any issues with those. I did look at some of the reports, and it seems like there is. Oh yes, go ahead.
Hi, we do have a question from Loanne Bonde. You may now begin.
Okay.
Loanne?
Hello?
Hi, you may go ahead with your question.
Sorry, my mute was on.
Okay.
The thing that we've been disturbed about is the number of patients' reports that we get back from Medicare that have nothing to do with their colonoscopy. So you spend a lot of time searching out, what exactly has gone on and whether there was any relationship.
So because they're all unplanned and it doesn't matter, what they came back for. So it's hard to filter through ones that have any connection having to do with the scope is what you're saying. So it's just a massive report to be able to identify issues with the colonoscopy, whether it's quality or maybe coding or anything like that. Has anyone else shared the same experience?
Okay, we have another question from Krista Stapleton. You may now begin your question.
Actually, it's not a question.
Okay.
It's in regards to also getting the report and having it be a colonoscopy that 4 days later they were admitted with exacerbation of their COPD. So something that really wasn't relevant to the actual procedure, and we're getting the same thing.
Okay. So
we're trying to go through it to see what connection with the actual scope.
So it's very time consuming to be able to sift through the report and see if there's any correlation to the admission within 7 days and tie it back to the colonoscopy. Okay. Has anybody sent in anything to CMS questions about that report or the measure, I guess, about how cumbersome that report is to get through? That's perhaps something we could take back. Maybe in the next the next OPPS, the ASC proposed rule, there's always a comment period where you could submit any suggestions, requests, or clarification you need. That might be a place to share your concerns also, and that will probably be out mid-summer, or to submit to concerns that if the measure is just, the data is enormous, and to be able to get through it to identify any issues is not the easiest task, I guess, for lack of anything other words. So, but it sounds like there's more places experiencing it, and so at least 2 on this call, so I'm sure it's more widespread.
Donna, we do have a question in the chat about where to find the claims detail reports.
Okay. So they are in your QualityNet inbox. They usually auto-route those hospital-specific reports to you. So if you have a QualityNet login and you go into your secure file transfer, you should be able to access those via the auto-route inbox. If you have any problems, feel free to call us. Our numbers are there. We can help you with that. There are other reports that you can request that are just claims detail reports, but they're not these hospital-specific ones that they send to you. And remember, too, when you get those in your inbox, you only have 60 days, I believe, before they are removed. So if you don't access those and download them, you won't have them after 60 days.
Okay, our next question comes from Sophia Jagerman. You may now begin your question or your discussion.
Thank you.
Sophia? You may have your call on mute, your phone.
Cynthia, are you there?
Maybe her call. It seems like she's still in queue, but it doesn't appear that she's saying anything.
Okay.
Sophia, if you can hear us, you may now begin your question or discussion. Okay, that's when she hung up.
Okay.
We have some additional posts in the chat box. So when are the claim detail reports published?
Okay. So there was the dry run that came out in, I believe, July of 2015. And then there was one came out in September of 2016. December of 2016, and the last one that I'm aware of came out in March of 2017. So if you did not access those at the time, within 60 days, you would not be able to access those now. It's possible that you could contact QualityNet Help Desk, and they may be able to still access those and upload them to your box if you tell them that you weren't aware they were there, or whatever the reason was that you were not able to access those in that time frame. If you were not even aware they were there, they will be able to help you with that.
There's an additional comment in chat that says the part that's beneficial about ASC 12 is that it provides information for comparison against the physician's report and allows to provide physicians with feedback.
Okay, thank you. So I think that with that ASC 12 or OP 32, they aren't really they wanted to be able to monitor for a period of time, and so I don't know that they're necessarily looking that something is not right. I think they just wanted to really kind of just throw a net out there and see what they came up with, is what it seems like to me. So, okay, if there's not any further discussion on OP32, we can move on. We'll now move on to OP37 or ASC 15. This is the last measure we want to discuss today, and this is the Outpatient Ambulatory Surgery Center Consumer Assessment of Healthcare Providers and Systems, or CAHPS for short. CAHPS are from a family of surveys that are overseen by the Agency for Healthcare Research and Quality, or AHRQ. The surveys ask consumers and patients to report on and evaluate their experiences with healthcare. And the surveys serve as a means for comparison data across the specific settings of care that's meaningful to patients. And you may be familiar with the HCAHPS for hospital settings or the CGCAHPS, which are used for clinic or group settings. And OAS CAHPS are specifically designed to capture feedback from patients in the outpatient ambulatory surgery centers. As with all HCAHPS surveys, there are strict rules about administration of the CAHPS, and it has to be conducted with a random sample outpatient surgery or procedure in the sample month. Methods for collecting the CAHPS survey responses include mail or telephone or a combination of both. The survey must be administered by a CMS-approved vendor. The HCAHPS topics are about communication and care provided by the healthcare providers and facility staff, or preparation for the surgery or procedure, and preparations for discharge and recovery. So the measures, there are in total 37 questions, and for ASC there are ASC 15A through E, and there are several questions in each of those measure sets to equal the 37. There's an additional 13 remaining demographic questions. For the OP37, again, the same 37 questions, and but there is a composite that's made up of OP37, A, B, and C, and then there's the global 37D facility and recommendation of the facility. The OAS CAHPS was voluntary for calendar year 2017. However, beginning with calendar year 2018, OAS CAHPS will affect your payment determination for calendar year payment 2020. This data will be publicly reported, and there is a link that we will post also on the chat to the final rule for further information regarding this, the measure, as well as a link for the OAS CAHPS website for more information. Again, the data collection for 2018 will affect payment determination 2020. The data will be collected monthly and submitted quarterly. And you do have to have a minimum of 300 completed surveys in the year. And now, if we want to start a discussion about the OAS CAHPS, this would be the time to open up the lines for discussion. And Emily, if you could also pull up the evaluation questions, that would be wonderful. Thank you.
Ladies and gentlemen, if you like, I'm so sorry.
No, go ahead. Go ahead.
Okay, ladies and gentlemen, if you would like to ask a question or you have a discussion, please press the number 1 key. Again, ladies and gentlemen, if you would like to ask a question or a discussion, please press the number 1 key. And our first question comes from Marilyn Dino.
I am in a small critical access hospital, and I've been asking the question if this is mandatory for our hospital. We do have an outpatient surgical center, but I haven't been able to really get an answer.
Okay. Because as a critical access hospital, you're not eligible for the quality reporting annual payment update, you wouldn't be required to do
that. Perfect. Thank you so much.
You're welcome.
Again, ladies and gentlemen, if you'd like to ask a question or a discussion, please press the number 1 key. If you'd like to ask a question or you have a discussion, please press the number 1 key.
There are a couple of posts in chat, Donna. There's some concern about the process related to the OAS CAHPS, and it sounds like the Ambulatory Surgery Association is lobbying to postpone until it's an electronic version and has less questions. We know from our work with other settings of care that hospitals and clinics have had similar feedback related to the clinician and group in the hospital CAHPS as well. So we'll see what comes of that. There's also some concern about the patient actually experiences the care and when they receive the survey. Similar concerns have been raised about other CAHPS surveys as well. Someone mentioned that they just implemented OAS CAHPS at their hospital and were surprised at how different the rating scale is compared to other CAHPS, that the bell curve for performance or percentile ranking is very tight. And it states that we have a measure that's around 97% top box, which is in the 43rd percentile. So really high levels of performance.
Great. Thank you for sharing that.
Ladies and gentlemen, if you'd like to ask a question, please, or have a discussion, please press the number 1 key. Ladies and gentlemen, if you'd like to ask a question and or discussion, please press the number 1 key. Thank you.
Does anyone plan to request an exemption for the OAS CAHPS? Or I'm just wondering if anyone else has started the process.
There's another comment in the chat that one of the facilities is looking to start on June 1st with press gaining.
Great. Anyone else that has already started that has any lessons learned or additional lessons learned or additional comments? Okay.
There's a comment, Donna. It is just in regards to the required submission period beginning in 2018. That says, like, if the facilities are waiting to start on the OAS CAHPS, then do not wait too long, and kind of like give yourself some time to develop a plan and how to implement the survey into your practice, because the 2018 is going to come up quicker than you think, and you're probably going to need more than just a couple months to plan. So it's always important to get ahead of the ball on that and get a process planned out, so that you are ready during the required submission period. So thank you to that, whoever said that.
Yeah, thank you. Okay. It is kind of your time for practice, is what we usually say when we know a measure is coming. And or if something is ever optional, voluntary, it's usually a measure that's going to be required down the road. So it's always good to take it on right away and work your bugs out, and that before it's actually required. So that's great advice.
Ladies and gentlemen, please press the number 1 key. Again, ladies and gentlemen, if you would like to ask a question and or a discussion, please press the number 1 key. Thank you.
So I think these measures are rather new still, and I think that there is probably more discussion we could have on them, but perhaps if you can, in the evaluation, just let us know what you would like to hear from us, because we are here for you, and we're just trying to facilitate this, but we will have data going forward that, perhaps we could share data and how, everybody's performing within the region, once we have updated data. And if you would like to see something like that, where we can actually give you performance status, and then, with some actual performance improvement tools too. But we really need to know where your needs are. So this is just, today was to try and get, together with the participants to be able to move forward. So we have provided on the slides here some references, different links to the Quality Net website where you'll find the help desk number and such, the specifications manual, and also the CAHPS links that we had mentioned earlier directly to the final rule, as well as the OAS CAHPS link. And then here is the contact information. So you contact, whoever's your respective state contact person here. We're all on the line now again, and I'm happy to field any further discussion today.
For folks, if folks are planning to hop off, if you could take a moment to provide us feedback. I believe the evaluation is available under polling on the right-hand side of your screen, so you should see a number of questions there where you can provide feedback on the event.
Thank you, Sarah. So, unless there's any further discussion, I think all right, thank you.
There is a question, I'm sorry, that came through the Q&A instead of in chat. What would be the reason that someone would be able to be exempt?
I believe it is due to their size, their population. So let me see if I can find it real quick. And so here, this is taken from a webinar from CMS that says requests for an exemption can be submitted if the facility treats fewer than 60 survey eligible patients during the eligibility period. The eligibility period is the calendar year before the data collection period. So you have to always, if you're going to submit a survey exemption, you would have to do that before May 15th of the data collection year. And there is a form available at the CAHPS website. So if you were to go to the top website, //oascaps.org, you would access the exemption form there, as well as other information regarding the OAS CAHPS. Are there any further discussion or comments, questions?
We just received a couple of questions in chat regarding the slides. So, Donna, do you want to speak to when they can expect to see those?
Sure. We will be sending out the slides by email by Monday, if not sooner. So anybody who is registered will receive that, all the participants. Thank you for that question.
And also the recording to this presentation will be available, and we will let you know when that is available as well. And that will be posted on our YouTube page within the next couple of weeks.
Yep. Okay. I'd like to thank you again for joining us, and I hope that you found this valuable, and I hope that you'll have suggestions and ideas for future webinars for us so that we can assist you in your quality reporting performance improvement. Thank you, and have a good day.
Thank you, ladies and gentlemen, for joining. You may now disconnect and have a great day.